Hello to you all and welcome back to my channel. My name is Tommy, I'm a human nutrition student and researcher at the university. What I do in these videos is to synthesize my classes so then I can explain and teach you the best and most valuable information you need to know. Today we're going to continue a series of videos called Physiopathology, and we're going to take a look at the water, minerals and pH alterations. So let's begin. Disorders of water and electrolyte metabolism. So here we have the volemia and the osmolarity. The volemia is the volume of blood and the osmolarity is the concentration of it. Body compartments. 1/3 of our body is extracellular fluid and 2/3 intracellular fluid, which is the space inside the cells. In the extracellular, we differentiate between the interstitial, 2/3, plasmatic, 1/3, and transcellular. The contents of the extracellular are water, sodium, chloride, and bicarbonate. In the intracellular, we have potassium and magnesium mainly. And these two are interchangeable using, for example, pumps. The sodium-potassium pump will interchange sodium and potassium. The normal osmolarity pressure is between 280 and 295 milliosmol per kilogram. The goal is to maintain those levels using the water osmotic properties. In an hypertonic medium, the water will come out of the tissues. In an hypotonic medium, the water will get inside the tissues. The Starling's law is the law of equilibrium of pressures, and the water follows it. For example, a low oncotic pressure and a high hydrostatic pressure will give edemas, because these are stimulating an hypotonic medium. Water balance. We have the inputs through drink, food and endogenous production of water, as well as losses, urine and feces mainly, but also insensible losses through the skin or when breathing. First is the desire to drink when reaching a higher osmolarity or hypovolemia, so low blood volume. Renal regulation of water inside our body is through the ADH, the antidiuretic hormone or vasopressin. It acts as a compensatory mechanism when there is high osmolarity, impeding the water excretion through the urine. Higher sodium ingested will equal a higher sodium excreted with higher water reabsorbed. High sodium equals hypervolemia, so a lot of volume. Low sodium means hypovolemia, because water follows the sodium indeed. And the sodium, it is reabsorbed in 70% in the proximal tubule, 30% in the lobe of Henle, and only a 5% in the distal tubule of the nephron. Now let's take a look at the physiopathology. We have the hyponatremia, when the plasma sodium concentration is below 135 milliequivalents per liter, and the hypernatremia, when the plasma sodium concentrations are over 145 milliequivalents per liter. So we have several types here of hyponatremia. We have the hypotonic, which can be euvolemic, so same amount of volume, hypervolemic, so more volume, and hypovolemic. We have the isotonic hyponatremia, which is called the pseudo-hyponatremia because glucose will trap some water inside, making it isotonic. That's why it's pseudo. And then we also have the hypertonic, as you can see in these drawings. So what are the steps to follow in the hyponatremia? We have to check that the sodium is really below 135. Then we have to measure the osmolality. Is it isotonic, hypotonic or hypertonic? And then we have to observe the plasma volume. Hypovolemic, euvolemic or hypervolemic. Euvolemic means that it's normal. And then we have to measure the sodium in the urine. Here in much more detail, hyponatremia, it can be isotonic, so the pseudo-hyponatremia, hypotonic hyponatremia, so hypovolemic, euvolemic or hypervolemic, and then also an hypertonic hyponatremia. The main cause of low sodium concentration in the blood is the SIADH, which stands for Syndrome of Inadequate ADH, which is the antidiuretic hormone secretion. And the treatment is administering an hypertonic saline solution. On the other hand, we get back to the hypernatremia. It happens when there are water and electrolyte deficits, always with much higher water losses than sodium losses. It can appear as a consequence of the hyponatremia treatment with hypertonic saline solutions. Of course, if we take too much of that solution, it can cause hypernatremia. And hypernatremia in dehydrated people is because of renal and extrarenal losses. In normal hydrated, it can be the diabetes insipidus. And in the edematodes, iatrogenesis or ingestion of too much seawater when swimming, for example. The urine osmolarity is less than 300 milliosmol per kilograms. Then it is because of diabetes insipidus. Urine osmolarity is greater than 600 milliosmol per kilogram. It is an adequate response with ADH. As you can see here in this little drawing, hypernatremia. Hello brain, this is the hypothalamus. Say we've got a problem. Sodium and osmolarity are up. My guy here is really thirsty. Brain here, thanks for the info. I will pass it on the pituitary gland. Pituitary gland here. I'm releasing the antidiuretic hormone, the ADH. I'm so thirsty. And then kidney here. I'm cutting back on urine output to increase dilution of sodium and osmolarity. Hypernatremia due to dehydration. Watch for signs of thirst, fever, dry mucous membranes, hypotension, tachycardia, low jugular venous pressure, and restlessness. The treatment is to replenish the water deficit. Drink. Hydrate yourself. Now let's talk about the disorders of potassium, calcium, and phosphorus metabolism. Potassium, 4,000 milliequivalents in the body. 98% of it is intracellular and 2% extracellular. The intake can be from the diet, mineralocorticoids, or acid-base balance. And excretion, renal 90% or intestinal at 10%. As you can see here, it is secreted the majority of the times in the distal convoluted tubule here, together with protons. Things that will enhance the excretion of potassium are diuretics, osmotic diuresis, mineralocorticoids, and alkalosis. And here we talk about the sodium and potassium pump. 2 of potassium go inside the cell, and 3 of sodium come out. The most important factors in the clinic regarding potassium are the catecholamines, the insulin, and the alkalosis. These 3, if they are increased, they will increase the potassium in the intracellular space. And here we have to differentiate between hypokalemia and hyperkalemia. Hypo is when the concentration is below 3.5 milliequivalents per liter. Hyper when it is above 5 milliequivalents per liter. Causes of hypokalemia: catecholamines, insulin and metabolic alkalosis, as we saw here, as well as lower intake, higher losses because of diuretics, and the renin-angiotensin-aldosterone system. The consequences are muscular weakness, affecting the skeletal muscles, paralytic ileus in the intestine, and arrhythmias in the heart, so affecting the 3 types of muscles. And we also have renal consequences, metabolic alkalosis, and diabetes insipidus, due to insensitivity to the antidiuretic hormone. Hyperkalemia, on the other hand, the causes are the reverse, so no catecholamines, no insulin, and a metabolic acidosis, as well as higher intake of potassium, lower losses because of some drugs, and tissue destruction. If you destroy a tissue, all the potassium is going to get out of the cells. The consequences are similar: muscular weakness, paralytic ileus, and arrhythmias, as well as renal consequences, metabolic acidosis, and higher bicarbonate elimination. Now let's talk about calcium. 99% of it is in bone for support and 1% circulating, and it is used for coagulation, nerve conduction, and muscle contraction. The PTH, the calcitonin, and the vitamin D. Very important. The PTH is hypercalcemic, increases the calcium but decreases the phosphorus in the blood. The reverse in the urine. The calcitonin decreases both calcium and phosphorus, and the vitamin D increases both calcium and phosphorus. Therefore we have hypoparathyroidism and hyperparathyroidism. In the hypo, there is an absence of the parathyroid glands, or physical and autoimmune glandular damage. It creates hypocalcemia and hypocalciuria with hyperphosphatemia, because in the PTH they are inverted. In the hyperparathyroidism, it can be primary because of parathyroid adenoma, secondary due to hypocalcemia, tertiary due to renal transplantation, or ectopic because of an extraparathyroid tumor that creates PTH. It causes hypercalcemia, osteoporosis, myopathies, and anemias. So here we get to 2 situations. Hypocalcemia with the hypoparathyroidism when calcium is below 8.5 milligrams per deciliter. Decreased blood calcium or increased calcium to the tissues. These are the causes. The hungry bones, the tumors, the pancreatitis, as well as low vitamin D in the diet or through the sun. This creates paresthesia, tetany, convulsions and arrhythmias. On the other hand, the hypercalcemia is when the calcium levels get over 10.5 milligrams per deciliter due to increased blood calcium because of the PTH, vitamin D or maybe tumors, or decreased calcium to the tissues, for example in the Paget's disease. Acute one causes arrhythmias, acute renal insufficiency and neurological problems. The chronic one creates digestive and renal disturbances and calcifications. So if there is low calcium in the blood, the parathyroid hormone with the PTH will stimulate the release of calcium from the bone. It will also reduce the calcium lost in the urine, it will activate the vitamin D in the kidneys, and the vitamin D will increase the intestinal calcium absorption. All these three things will restore the normal calcium levels, and the normal calcium levels in the blood will inhibit the PTH secretion. On the other hand, a high blood calcium, the calcitonin starts to act. So from the thyroid gland, it will inhibit the release of calcium from the bone, and in the kidneys, it will increase the calcium lost in the urine. These two things will restore the normal calcium levels in the blood, and this will inhibit the calcitonin secretion. Now let's talk about the phosphorus. It is high in the intracellular space and low in the extracellular, mainly in the bone. Always opposite to the calcium. Very important to understand that. In an hypophosphatemia, phosphorus is below 2.5. In the hyperphosphatemia, it is above 4.5 milligrams per deciliter. In the hypo, we have lower inputs, for example, low vitamin D, because vitamin D increases the phosphorus as well as the calcium, or higher losses of, for example, the PTH. And this creates rickets, osteomalacia and muscle weakness. In the hyper, we have higher inputs due to tissue destruction and also parenteral nutrition, or a lower elimination, for example, in the chronic kidney disease or lower PTH. It creates hypocalcemia and calcifications. These are rickets and osteomalacia due to hypophosphatemia, and this is a calcification of an artery due to hyperphosphatemia. And now we talk about acid-base balance. So you have to know that there is a pH scale that goes from 0 to 14, and that water and our blood should be around 7, so neutral pH. Let's take a look at the acids. We have volatile acids and fixed acids. In the volatile acids we have the CO2, which accounts for the 98% of the total acid load, which is very, very high. On the other hand, the fixed acids only represent the 1 to 2% of the acid load, and these come from the oxidative catabolism of micronutrients. The volatile ones are eliminated through the lungs and the fixed ones through the kidneys. If there is a high ventilation, we will lower the amount of CO2, therefore creating a respiratory alkalosis. The reverse also happens, so if our ventilation is lowered, therefore the CO2 starts to accumulate and we will create a respiratory acidosis. If there is a metabolic acidosis, we will excrete a lot of protons and reabsorb a lot of bicarbonate. And in the alkalosis, we will do the reverse. We will reabsorb the protons and excrete the bicarbonate. And here we have to talk about the physiological buffers. The regeneration needed, limited and short-lived action. These are the main characteristics of the physiological buffers. We use them to find the optimal pH in every tissue. Intracellular, we have the proteins, inorganic phosphate and calcium carbonate from the bone. Important. In the extracellular space, we have the carbonic acid bicarbonate. So, what are the reference values for the pH? From 735 to 745. For the pressure of CO2, from 35 to 45 millimeters of mercurium. So very easy. Same as pH without the 7. And the bicarbonate levels between 24 and 28 millimoles per liter. So now let's take a look at acidosis and alkalosis. In an acidosis, metabolic acidosis is due to low concentrations of bicarbonate when it gets below 24, and the pH, of course, because it's acid, below 7 and 35. Respiratory acidosis is due to high CO2, higher than 45, and in the alkalosis is the reverse. So metabolic alkalosis is high bicarbonate over 28, and respiratory alkalosis due to low CO2, so below 35. Now something very interesting happens, because in a metabolic acidosis we have a respiratory compensation with a higher ventilation. We start to breathing a lot. And in a respiratory acidosis we have a metabolic compensation. We increase the bicarbonate. And the reverse also happens. In the metabolic alkalosis, the respiratory compensation is with lowering the ventilation. And a respiratory alkalosis is by lowering the bicarbonate. Okay, so now let's take a look at osteopathies. We have the osteoporosis, the rickets and Malaysia, and the Paget's disease, as well as the osteomyelitis and the bone tumors. Let's start with the osteoporosis. It's the systemic skeletal disorder characterized by low bone mass. It can be primary due to senile or postmenopausal factors, or secondary due to sporadic factors. It is correlated with lower calcium intake as well as low vitamin D, with consumption of alcohol and smoking, sedentary lifestyle, caffeine, and lower estrogens, especially in women in the postmenopause. It causes vertebral fractures and deformities. As you can see, this is the difference between a normal bone and the osteoporosis. The rickets and osteomalacia are a softening of the bones caused by impaired bone metabolism. Here we lower the mass, as in the osteoporosis, but we also lower the volume. It's due to inadequate levels of available phosphorus, calcium and vitamin D, or because of resorption of calcium. It causes bone pain, muscle fatigue, crushing of the spine and bone fractures. And this is the difference between normal bones and rickets. As you can see, they are bent. The Paget's disease now. We talked about this before. Now let's view in more detail what it is. It is an accelerated but defective bone tissue turnover. So we create a lot of bone, but it's softer and weaker. Phases. We have the lytic one, bone resorption, high osteoclasts, the ones that degrade the bone, and higher vascularization. Mixed. Bone remodeling. So higher osteoclasts, a lot of degradation, but also high osteoblasts, the ones that create the bone. And then we also have the osteoclerotic phase, when there is low replacement, lower osteoclasts, lower osteoblasts, and lower vascularization. There are no symptoms, and if any, it is bone pain. It can be specific or generalized. Again, this disease is the rapid remodeling that creates new bones softer and weaker than the normal ones. The osteomyelitis is an infection that usually causes pain in the long bones in the legs. It is related with the Staphylococcus aureus in the majority of the cases, and it causes pain and lump in the bone, redness of the area, fever and possible pus. As you can see, this is an example of osteomyelitis. And then we have bone tumors. It can be benign or malignant. The benign ones are the osteochondroma, the chondroma and the osteoma. The malignant, the osteosarcoma, the Ewing's sarcoma and the chondrosarcoma. The difference is that the benign ones are cells from normal tissue that grow slowly and they do not invade the neighboring structures, so they stay where they are. The malignant tumors are cells different from the normal tissue. They grow rapidly and they invade structures and they can metastasize. And this is an example of a bone tumor. Okay, that's it for this video. I hope you understood everything I said. If you didn't, there is a comment section down below. Remember to download this diagram by clicking the first link in the description. Don't forget to like, subscribe and turn on the notifications so you get notified every time I upload a new video. Share this video to your friends and family if you find it helpful, and I will see you in the next one. Ciao!